Community Services Limited, a charity providing substance use recovery services for marginalized groups in Singapore, and is co-lead of Project Hayat, a community-led initiative to develop a national suicide prevention strategy in Singapore. His broad research interests revolve broadly around stigma and health, community engagement, implementation science, and health equity of vulnerable communities. And Dr. Rayner is going to talk to us today about sexualized substance use in the Asia-Pacific region. Rayner, please go ahead. Thank you.
Thank you. While the slides are loading, I just want to thank the organizers and thank the co-chairs, co-moderators for the opportunity to present here today, and just very happy to see everyone here. So great, okay. So I will be talking a little bit more about sexualized drug use in the context of the Asia-Pacific region. To do so, I'll just cover 4 main points. I think the first one is to really define what we mean by sexualized drug use, and many of you might know we might be using a lot of terms, right, that are actually interchangeable here when we refer to sexualized drug use. So being able to define it, I think, is pretty important. Thereafter, I'll talk a little bit about, traditionally what our response has been when we're thinking about substance use or sexualized drug use in general, before moving on to, what I guess can be done or what has been done in the region, a very brief, like a primer to that. So what exactly is sexualized drug use? And here I introduce the word chemsex as well, right? Because this is a word that we have been hearing a lot in discourse around HIV prevention too. And in general, sexualized drug use, at least what we know, I think, and what I see, is that it's a much broader kind of like umbrella term. And I think mainly highlighted the different types of substances and drugs that are out there, right? And these include stuff like marijuana, alcohol, stimulant type substances, and they are all substances and drugs. So sexualized drug use in general, I guess, would mean more broadly the use of these substances or drugs in the context of sex. Whereas if you think about the word chemsex, historically, actually scholars have argued that chemsex refers to this very specific confluence of a few things. So some would argue, and many would attribute the term chemsex to what the late David Stewart was describing back in about 2014. So he was describing this phenomenon, right, a sort of a cultural phenomenon where people in the UK were, engaging in sex with a few types of substances, specifically mephedrone, a type of stimulant, GHB, gamma hydroxybutyrate, as well as other kinds of drugs involved. And this was done in the context of the rise of hookup apps at that time. For example, Grindr. And I think this caused some alarm back in the day where people were talking about how chemsex is this huge panic and a wave of like a risk that we need to keep a lookout for. So in that sense, actually the term chemsex does kind of refer to that specific confluence of those types of substances as well as that cultural phenomenon, whereas sexualized drug use might be a little bit broader. However, we often see that these terms are used interchangeably in the academic literature, which kind of confuses things a little bit, because sometimes you read a paper and you might actually see chemsex refer to the use of, say, any type of substance, and this might also refer to alcohol or even amyl nitrites, or which are poppers. But you can imagine that the context for each type of substance used in the context of sex is actually quite different. The potency of each drug, beyond just the potency or the biochemical nature of these interactions, but even the relational or the social context in which certain drugs are used are actually quite different as well. So being actually sort of conflating all of them really doesn't help us find out more about what we can do to address chemsex or sexualized drug use. Beyond the definition and the types of substances, there are also different types of practices. And in the specific chemsex literature, when I talk about chemsex, we think about the more classic mephedrone, methamphetamine, stimulant type drug use. There is this practice also called slamming or slam sex, and this moves us from what type of substances are being used towards something more defined in terms of, let's say, how it's administered as well. So, I think there's been a focus on slamming or slam sex, or, I think in more Western contexts, words like pointing would also be used. And this also is important because, it actually introduces this new confluence of risks involved, right? We often think about substance use related risks for HIV for people who inject drugs. I think for injection drug risks, you might be thinking of outcomes such as HIV, risk of acquiring hepatitis C, and so on. But you imagine when it comes to chemsex, when you're administering drugs through needles, you're thinking about the risks of sex as well as injection drug use together at the same time. And that's why there's been a focus on this form of administering methamphetamine specifically, or other stimulant type substances. And I think when we think about the ways that we talk about chemsex, we also should not forget about how the community talks about chemsex as well. If you go out in at least Southeast Asia and you talk to people and ask them whether they practice chemsex, I think people can kind of know what you're talking about, but they don't really use the term chemsex actually. I think people on Grindr, on hookup apps, they might be using emojis to sort of discuss chemsex related practices, and these are specific to sort of the use of, let's say, crystal meth, or the street name being ice, right? And that's why you see these emojis kind of refer to these the use of ice, the use of crystal meth, and people might be using this because they do not want to explicitly say that they are using certain types of substances as well. However, I think these are quite obvious nowadays. You kind of know that people are using ice or are looking for chem fun or chemsex when you see these emojis. I think because of the it was a little bit too on the nose. I think in some contexts we have moved to a little bit more discrete emojis, including some of these over here, and you will be seeing a lot of short forms like HF, which we refer to high fun. And I think that's a more common term that we see. In Singapore, we often see like CF, which refers to chill fun. And the reason why it's called chill fun is because chill is like cold and cold is ice. And people would just use some of these code words to communicate with each other as well. And actually one thing that is really important, which I want to highlight, is that when we talk about sexualized drug use in general, we're talking about something much broader. But if we want to look at specifically what we traditionally think about when we think about, let's say, risks for HIV acquisition, high fun and chill fun are actually specific practices that we might want to look deeper into, right? Because when you use drugs such as crystal meth, some other types of stimulants, you're thinking about sex that happens over maybe multiple days, having maybe like multiple sexual partners. When I think about prep surfing, that's also, I think, really interesting concept as well, because when it comes to multiple partners and group sex settings, sometimes you're only communicating with one person in the group sex setting about their PrEP status or their HIV status. And when more people get added to that group context, you actually don't really know what their PrEP status or their HIV status is as well. So, I think these are some things to consider, because you imagine that if you're thinking about crystal meth, this is a context. However, if you're thinking about alcohol, or maybe let's say marijuana, you might not be looking at the same type of risk profiles or the risk context as well, because the effects or the potency for those types of drugs might actually be a bit more short-lived, or there are maybe different kind of social or relational aspects to those types of substances. So I think it's important, even though right now the literature is talking about sexualized drug use or chemsex quite interchangeably, covering a wide range of substances, it's important to really look at the context for each type of substance and each type of maybe the drug using context as well. These are some of the terms that you might see outside of Asia. People might be using things like wired sex, party and play. However, I think because we are very globalized right now, in terms of not just industry, but in terms of how people travel, you will see that a lot of these terms people might be more familiar with over time. Yeah, but I think traditionally we've been talking about all these things. Has it been raising alarms? Has it been gaining more prominence? Yes, in 2023, I think this is when we first saw the UNAIDS global report or global AIDS update mention something like a sexualized drug use in Asia. I think this was referencing a very nicely done scoping review, I think by APCOM and many different community partners on sexualized drug use in Asia. And this was when I guess alarm bells were being raised again to turn our attention to this. But how well have we been measuring chemsex or sexualized drug use? As of today, I think we've been measuring really well different key populations at risk of acquiring HIV, including people who inject drugs. But when we look at people who inject drugs, you might be asking yourself, how many of these people, or what is the proportion of people here who are practicing, for example, injection drug use in the context of sex, for example? We don't really know what this proportion is. And when we think about chemsex or slamming, sorry, I added Bluetoothing there. You can Google it or you can search for it. But I think this is a separate risk activity that we often see, I think, coming out of Fiji. But anyway, for chemsex and slamming, what we can do when we look at the key population figures that are so readily available is just guess, right? How many MSM, transgender women, what's the proportion of them who practice chemsex? Among people who inject drugs, what's the proportion of them who are practicing slamming? These are some things that we can guess right now, but we don't really have a lot of data for on a global perspective. Consequently, when we're thinking about the prevalence of sexualized drug use in the region, you will see that a couple of days ago I attended a talk by Dr. Akarin, and I think based on that, I remember the prevalence was 2% to 80%, right, across the region. Imagine 2% to 80% across the region. I don't really know how to really interpret that, right? Is it that some places it's just difficult to find drugs, whereas some places it's just so readily available that 4 out of 5 people are engaging in sexualized drug use? But I think one of the issues here is that there's an issue of measurement or definition of what drug is, right? Because when we include drugs such as alcohol in our definition, or poppers or amyl nitrites, these are some things that are more commonplace, right? However, if your definition of drug is something like ice or crystal meth, this is less commonplace, harder to find, and your prevalences might be a bit lower. And so this map over here is sort of like a heat map for MSM, and you will see that I wouldn't pay too much attention to the heat map components of it, because what this shows actually are many different measurements across many different types of substances. So one place might have, let's say, any type of drug. Any type of drug could include poppers, which is so readily available in many different places. But one thing's for sure is that while there are some measurement issues, when we look at the map for transgender women, for example, there's also much less data available. So we do know that while there are measurement issues, there's also still a bias in terms of where we are looking at in terms of measuring chemsex or sexualized drug use as well. So there are much more gray areas on this map here, showing that we still do not pay enough attention to non-MSM key populations who are engaging in sexualized drug use or chemsex. I think this year was the first time we ran a workshop in Munich for AIDS 2024, and we were actually trying to think deeper around conceptualizing, defining, as well as measuring chemsex. And we did this exercise where everyone were in parts of different regions. So we were trying to see whether there were regional differences in how chemsex were defined or measured. And I think one thing that came up is that we cannot have for example, let's say Southeast Asia, we're thinking of high fun or chem fun or chill fun. We think about ice or crystal meth, right? We cannot assume that this is the kind of substances that we must pay attention to in every different region. And maybe in, let's say, South Asia, or some friends in, certain countries or jurisdictions in Southeast Asia, they feel that our focus should be on alcohol, because alcohol is readily available and it's also a problem in our own country. This is something that I think we should allow different places to define, but one thing that we can agree on is that we cannot have a simple single definition that really covers everything. I think that kind of undermines or underplays the effect of specific substances and its implications for HIV acquisition or risk. So what has our response been, for sexualized drug use in the Asia Pacific? I wanted to introduce this concept of the rush to risk, right? And I think one thing that we do know is that in this region, there has been a move towards more punitive drug laws that preclude harm reduction approaches. There's a war on drugs, and there's been just traditionally more stigma and discrimination towards people who use drugs. And when you have these social legal barriers towards addressing drug use, I think what you often see is this divergence, right? This polarization of services for people. One is that you don't do anything because it's difficult to do stuff, and the other end of the spectrum is that there are jails or mandatory rehabs that you can go to. So it's like zero to nothing, and that's the case for where I'm from, right? Typically, like in Singapore, you've got the death penalty for drug use, for presumed drug trafficking limits and stuff, and the only rehab that we have in my country is the mandatory rehab that's located inside the prison. So actually, it's not really it's a rehab, but it's actually a prison cell. So that's not really ideal, when it comes to recovery for chemsex and sexualized drug use. I think when you see, I was trying to find a figure that sort of showed the variety of services across the region, but I think this chart over here from Harm Reduction International is a nice way of also showing what kind of focus or efforts are being made in the region for harm reduction, right? And I think harm reduction, because of that polarization of like jail, prison, mandatory rehab, and doing nothing, you can imagine that harm reduction actually sort of is this area where it paints between these two lines, right? It recognizes that different people have different practices in terms of drug use. It recognizes and acknowledges the continuum of drug use that Meng Li had shared earlier. And if we are able to see how these harm reduction practices are available in different places in Asia, perhaps we can also see where some of these services are as well. But if you look at this chart over here on the right hand side, you'll see that there are mostly X's in most parts of Asia, because I think legally and socially it's hard to sort of roll out harm reduction services. Like how in Singapore we don't do harm reduction. There's no such thing as harm reduction. It's a harm prevention approach. We have only abstinence-only programs, for example. You can see all these over here. And one thing I will point out is that these harm reduction responses, traditionally when we think about PWID, people who inject drugs, these are very relevant. But when we're thinking about chemsex or sexualized drug use, actually harm reduction approaches that have come from the harm reduction kind of literature may or may not actually be very relevant to the kinds of practices that are involved when you think about chemsex or sexualized drug use. So like, for example, opioid agonist therapy, because let's say high fun or crystal meth involved fun, does not typically involve opioids or opiates. Naloxone is also not that relevant when it comes to a lot of the chem fun or high fun kind of context. So these are some things to think about as well when we're thinking about our response. But one thing that's also important is to really think that when we rush to risk, when we immediately think that all substance use is risky, one thing is that first, I think I'm not trying to say that we shouldn't think about risk when we're thinking about substances. There are definitely risks involved, and we have seen the implications of that when it comes to, let's say, greater incidence for HIV, for example, in certain communities. However, when we rush to thinking about that, it's harder for us to think about how we can do more comprehensive harm reduction services, because we immediately jump to the risk without thinking about how people use things, why people use substances, or what the meaning for substances are for different people. So this also aligns with what Meng Li was talking about earlier, that we need to acknowledge non-problematic drug use. Because in my experience also delivering substance use recovery services with one of the Singapore organizations, right? We used to assume that everyone who showed up using crystal meth had a problem, and what happened was half of these people would get turned off. They would feel like we are assuming that they are all addicted, that they all had dependence, and we were not meeting them where they were at. So this is one of the issues that would come up. If we assume that everyone has a problem, we need to also really think about the social context in which drugs take place as well, and move beyond just biomedical forms of understanding. We often think about, let's say, the risks involved when we use drugs, intoxication, inebriation and stuff. But if we don't really understand the sociological or the cultural aspects of drug use, it's harder for us to intervene and actually do something, when it comes to reducing the harms associated with sexualized drug use. To that end, what actually should we be looking at when we're thinking about addressing sexualized drug use or chemsex? First, have said this multiple times, so I won't repeat it. There's this spectrum of non-problematic towards, I guess, dependence. This is pretty much the same picture or the same continuum that was shown in an earlier presentation, from non-use towards substance use disorder. And there have been some attempts at reviewing the proportion of people who identify as being problematic users for different substances. And you can see over here that even for substances that we think of as like really hard drugs, such as stimulants or methamphetamine, there are a proportion of people who do not feel that they have problematic use as well. However, one caveat here is that I'm not so sure how the word problematic is defined in these studies. This is something that needs to be thought of more critically, I guess. But one thing's for sure is that many people use substances and engage in sexualized drug use or chemsex for many different reasons, right? We often think that immediately, if we think from one perspective, it might be a coping mechanism to stigma and discrimination, which is a very real purpose of why people might use substances or engage in chemsex. But also, there are many positive aspects that chemsex or sexualized drug use can give people, starting from the pleasure, right? People do it because it's pleasurable, that people want to enhance their pleasure when it comes to sex. However, there are also other social and cultural aspects. So, for example, feeling freedom, feeling some pride and empowerment, feeling beautiful, having some form of a social power or community identity. These are the different things that might resonate with different people when it comes to sexualized drug use or chemsex. This is something that I think reflects the kind of journeys that we have taken in terms of trying to provide services to people who engage in chemsex, at least from a Singapore perspective. I think one thing that we realized, and this was something that Meng Li mentioned also, some people are not ready yet, even though the services are there. And this actually speaks to the journey that they're on currently, right? I think just like how, maybe I have my own academic journey. I start with a bachelor's degree towards a PhD, towards, different aspects like a postdoc, etc. Being a chemsex, someone engaging in chemsex also has their own journey, right? How they start to learn about chemsex, how they learn how to use, towards a certain point, maybe there is a realization that there are some risks involved. There is a certain kind of journey involved there. The other thing to think about is that when we're trying to reduce harms, we have to think about the environment in which chemsex or sexualized drug use takes place. And this might differ from one type of drug to another drug, but we have to really think about what happens when drug use is happening with sex, and what are the things that we can do to make things safer at that event itself. And finally, we also have to think about life histories, right? I think if we're thinking about coping mechanisms, if we're thinking about how drug use or sexualized drug use or chemsex is used as a coping mechanism, coping from what? Right, and I think you're not just coping from something that's based on the event, but you're coping from something that is very trauma-informed, right? You're coping from something that has been happening maybe throughout your whole life course. So being able to understand, what people have been through can help us better understand the role that chemsex or sexualized drug use plays in a person's life. So these are some examples. If you're thinking about journeys of chemsex, there have been papers out there that look at people's typical journeys when it comes to chemsex. This is one example of them. So this particular chemsex journey talks about how loneliness and emptiness, searching for connection, getting sexual connection and chemsex connection, and finally leading towards like problematic chemsex and severe health impacts is one type of journey that we can think about. It's not always the case here. Some people, might be able to just stop at finding that connection. They don't actually have dependence issues, and they don't really experience problematic chemsex or have severe health impacts. But this is something to consider when we are engaging with someone who is coming for services, right? Are you facing issues? Are you facing severe health impacts, or are you trying to find out more about yourself and your own use? This trans-theoretical model of behavior change might also be familiar to, let's say, counselors or psychologists, trying to engage in behavioral change work or health behavior change work, right? Many people who are engaging in, let's say, certain health or behaviors might be at different stages of change. And, if we're trying to deliver a comprehensive harm reduction service, is that person ready for change yet? And, there are also methods and modalities that help someone move from pre-contemplation towards action, right? These involve motivational interviewing techniques. These involve certain kinds of even screening tools, right, that allow people to appreciate that they are at risk for certain things, or maybe they acknowledge that there are certain harms that happen in their own lives that they might not actually be as well aware of until someone talks to them about it. Right? These are some things that happen when we do motivational interviewing, as well as have psychological intervention for such folks. Moving on to event space, beyond just the chemsex journey, there's this event level context, and there are actually studies, this review done by Dr. Carol Strong and colleagues, to really see what we can do before, during, and after chemsex, to reduce the harms associated with 3 areas, right? Because with chemsex, there's the HIV-related risk, there's the drug-related risk, and the sex-related risk. So there are many things that you can do before, during, and after, including things like PrEP, doxy-PEP. You think about nutrition, drinking enough water, buying lip balm, like things like that. These are some things you can do to reduce the harms associated with chemsex or sexualized drug use. And then from a personal life history perspective, I think this is something that the community group that I'm with in Singapore aligns ourselves with, right? Our assumption is that people use drugs not because, or rather, people use drugs as a solution to their problems. Drugs aren't the problem in their lives, right? So if you take away the drugs from people, you're leaving people with a gap that, back to their own problems without a solution actually. So in our approach, where we are more trauma informed, our assumption is that, maybe there are certain traumas in someone's life that, people are actually using drugs to cope with. And this is our experience, at least, and we find that there are certain kinds of factors involved in someone's life course or life history that need to be dealt with in order to actually intervene and reduce or actually prevent someone from engaging in chemsex again. And the reason why we use this approach also is because in Singapore, we cannot have any harm reduction services. We can only have abstinence-only services, and that is the only thing that the government would endorse because of the zero-tolerance policy towards drugs. Finally, I think there have been very innovative approaches that I've seen in the region that actually reflect a lot of these like person-centered approaches towards sexualized drug use and chemsex. These I have gotten off the website of the Asia Pacific Chemsex Symposium, and I think this is a very important forum that takes place, regularly, right? And this was it this year? No, last year's one was in Bangkok, right here. With many of the organizers here also at the Bangkok Symposium. And I just wanted to show just some examples, right? In Vietnam, we can see some parallels with some of the literature out there. Before, during, and after chemsex, what can you do? And beyond just theoretically giving some examples or suggestions, the community groups can actually prepare, like intervention kits or these like harm reduction kits that allow people to stay safer or reduce their harms, before, during, and after chemsex or sexualized drug use. There are also efforts to screen, right? And I think one thing that community groups can do that academics maybe won't do as well is to, what do we do after screening, right? If we have a screening tool, perhaps they can then link people up to, different types of interventions or different kinds of care pathways that community groups are well placed to navigate. They can come up with different innovative care pathways themselves when it's community-led. And finally, there are also different types of chemsex psychosocial support systems, right? I think one thing that we realize is that, community groups might not be a one-stop shop, because a lot of our community groups, including the one that we run in Singapore, we only have like counselors, right? We don't have psychiatrists on board, but what if someone who needs care needs antidepressants? What if they need, Xanax anti-anxiety medications, to actually help with coping from, reducing, let's say, their sexualized drug use or chemsex? We can't do that, but we can offer peer support and we can offer case management services to help someone navigate through all these complex layers of care. So these are some things that can be done. In closing, I think there have been efforts to really think about what a comprehensive chemsex or sexualized drug use harm reduction framework might look like. I think these are the things that have been inspired by IHRI's work as well. I think there's a, I know that there is a climax study, a T-Rex study, and because of these studies that are being conducted, there have been very comprehensive harm reduction frameworks that have been that have been derived from the voices of the community. And you know what the community needs are, you know, the drug-specific harm reduction services, social support, mental health, sexual health, as well as rights and legal support. You know, and you know, these are all done in the context of, you know, being sex positive and pleasure centered, gender affirmative, you know, strengths oriented, and intersectionality informed. You know, when we can do this, I think we can do well in terms of providing such services. And you know, in closing, I guess, you know, there are opportunities on how we better define sexualized drug use or chemsex. You know, harm reduction is where we paint between the two polarized ends to actually provide people services where they are at. You know, I think, but nonetheless, all of us will know that in this region, there are major legal, political, social challenges towards addressing drug use. But you know, I think in the absence of that, community groups can also lead certain initiatives in the meantime, you know, to actually provide services to people. Yeah, thank you so much.
Okay, so thank you very much, Rayner, for a very comprehensive overview. Once again, in terms of the sexualized drug use, I think we can can have one question for Rayner if anyone has one. Okay, if not, I think before we. Oh, okay, sorry, Professor Martin.
Yeah, thank you. Very impressive talk. I was wondering on a very practical level, if there's punitive laws in Singapore and some other countries, how do you do actually research? Because in research you want to that clients or participants open up, or is all your research like anonymized, self-administered questionnaires? Or
I think it. Okay. At the first level, anonymous surveys have been more like they have been approved. So I think about like my work with the IRB, like the ethics board in Singapore, and if we do ask about criminalized behaviors, we do have to make sure that it's entirely anonymous, that the data cannot be linked to an individual's identity. And you know, I think with surveys that's a little bit easier. And even if we wanted to do like a cohort study, we could, because what we had to do was, you know, work with a community group. The community group would have, let's say, a key, a master key list where they have the identities of people with a study ID. But then the university has the criminalized data, but not the personal data. And so one group would never have a combination of both at the same time. And you know, we've tried to do in-depth interviews as well, and that's a bit harder because like I'm talking to someone face to face. But what I've gotten, we have gotten away with has been, okay, the community group can organize the interviews. I will show up, and I'd have no idea who this person is because I don't collect any of their details. But you know, I have their interview data, whereas the community group won't have it. I think it's a lot easier now with like online teleconferencing software, where you can actually have someone attend that interview at a community group setting, and you know, it's like there's no video, as a pseudonym use. So I think that has allowed us to do things. But in short, I think we have to make sure that it's anonymous. Yeah.
Okay, so this kind of brings us, I guess, to the panel discussion portion of the session, and maybe the distinction is a bit arbitrary because you know we've been hearing a lot from the presenters, and questions have been posed to them, and this is just really a kind of continuation of that process. So again, we're happy to invite and encourage anyone with any further questions for panel members, you know, to come up and use the microphones that are there in the middle of the room. And but whilst that happens, and in the meantime, I'm sure Akarin, who's just put his hand up, and myself have plenty of questions, you know, based on the really interesting and important work around PrEP and substance use services that the panelists have been presenting. So Akarin, please.
Sure, thank you very much, Jeremy. So I think before we move to maybe kind of connecting all the dots together, one of the things that I think came up, at least from Rayner's talk about gain frame message, which I think I believe is kind of like the positive side of message. You mentioned a little bit in terms of substance use as well, that we usually jump to the risk. So that I think means that it would be great if we can integrate some like positive message. I'm not sure if I can use the same vocabulary as gain frame message, but I think one distinction here is that PrEP is, apology to say it very bluntly, PrEP is not illegal. Now for substance, you may face a lot of obstacles, especially from like the policymaker, etc., trying to convey a positive message. So what's your opinion, Rayner, and perhaps P. Rayner can join in here as well, in how to provide that thing that we all think we need, the positive side of things, rather than focus on risk, from the aspect of us healthcare provider forming a team, the training, and so on, but also communicating to the policy maker as well.
Okay, I can try and go first. It's a bit, I think it's a bit of a complicated answer, but a really great question. I think one thing that I often wonder also, right, is I come from a school of public health. We are allowed to get funding from alcohol industry, right? And you know, but we are banned from getting funding from tobacco industry. You know, and I wonder to myself as someone who does substance use related work, what's the difference? You know, like why are we allowed to, you know, have one substance fund research while other substances no? And you know, the reason that I often hear is, oh, because there are some benefits to alcohol, but you know, but for cigarettes there are like no benefits. It's like always harm. And I wonder to myself, is it because it's a very biomedical understanding of certain kinds of benefits that are conferred, you know, with certain kinds of substances? Because I have colleagues who have done work on, you know, the well-being around smoking. You know, it's in a social context. You know, but even then, that research is stigmatized. The research itself is stigmatized. That, you know, reviewers and scientists will be like, why are you conducting this kind of research? You know, to look at the benefits of something that is so evil, right? Not that I endorse any of these like types of substances, but you know, it kind of raises this question around like you know, like how can we have gain framed or positive messaging for certain types of substances, substance use patterns, when there are legal, social, and you know, maybe even some of these like academic issues involved in it. You know, and I wonder whether it's even possible, because even for community groups who are developing harm reduction resources, there is always a disclaimer to say that we are not promoting substance use. You know, whereas let's say if it were PrEP, for example, we want to promote PrEP, but we wouldn't say the same things. So I do see the benefit of approaching things from a pleasure-centered or, you know, a sex-positive game frame approach. I'm not so sure how much of it can be done from a social marketing perspective, but definitely from a psychological, you know, like relational perspective, that's something that we do already. You know, not to stigmatize people, to make sure that, you know, we meet people where they are at. You know, so hard to say whether we can do that at a large scale.
Yes, I think as Dr. Akarin asking, I think first of all, yeah, PrEP is legal, right? However, there's still many providers in our region still against it or don't want to prescribe it. I don't know, because of different reasons, or many of them I heard that they would like to promote condoms, and while they also devalue the PrEP use, which I think is inappropriate. You know, I think we should respect the informed decision of the clients that we serve. And when you talk about substance use, I think it's even worse because the drug itself is legal. However, I think we are very fortunate. I think at least in my context, we try to relate substance use or chemsex use with health issues. So that's why I think, Akarin, you can share definitely when we develop the study protocol on Climax, which is the chemsex use among young men who have sex with men. We receive multiple rounds of feedback and comments from our local IRBs. And we have, while we are working towards rules and regulation of research conduct, we have to sensitize those IRB who are sitting in the committee members as well. This is automatic work that we have to do to sensitize these researchers or healthcare providers who are part of the IRB committee. But in my context, I think when we are providing care to transgender people, I myself trying to overlook this issue for many years, but I had to admit that in the past 2 or 3 years, we saw the needs around sexualized drug use among transgender people that I serve at my clinic. And I cannot stop, I cannot pretend that I don't know about this issue. We have to ask our client, we have to understand them why and how it's related to their mental health, how it's related to their sexual behaviors, or is there any other structural barriers, for example, economic, housing, or even intimate partner violence that is related to substance use. So we have to understand the syndemic issues that linking them to the health vulnerability. So I think we very fortunate that we link substance use with the health issues. So this environment still allow us to work around. And
Thank you very much, Rayner and Piri now. And what you mentioned is actually our own experience, Rina, that we have to link it with some kind of health impact and something to kind of to facilitate our work.
And, maybe kind of to follow on, that train of thought and to think about kind of linking to health impacts and implications for service integration. So given, for example, high substance use rates and potentially sexualized substance use amongst, for example, transgender populations, perhaps Rina, you can talk a little bit about how that's impacted your integration of services, across a continuum that presumably includes PrEP services as well, because as we know, substance use potentially influences sexual risk behaviors, potentially influences PrEP adherence. So has this kind of, awareness of these sorts of problems and issues practically informed, your delivery and integration of substance use related screening and treatment services within your PrEP services, for example, at the Tangerine Clinic?
Yes, thank you, Jeremy, for your question. I think first, I would say that introducing mental health services at my clinic, which is a sexual health clinic, is also challenging already at first. So that's why it's led us to implementing, to conducting an implementation study to integrate depression, screening of depression into the transgender health clinic. And I think we learned a lot already from outside of Thailand, that when you talk about PrEP is also helps relieve anxiety among users who use it. I think it's also we also believe that by integrating people-centered care, for example, mental health is also really helpful for us to address other health issues. So after we successfully integrated mental health, for example, depression or anxiety or even post-traumatic stress disorder into the comprehensive health service package, I think it's really linking us to be able to offer other sexual health services as well. For example, if a trans individual who are newly diagnosed with HIV for today, what if our counselors or healthcare provider do not understand any aspect of mental health at all? How are we going to provide the appropriate counseling to the transgender client who just realized their HIV status on that day? So I think it's another important issue that mental health need to be integrated as part of the comprehensive health service package, providing for the key populations.
Martin.
So maybe I can raise a point in response to Rayner's talk. You said two things. One is in different places, different locations, different countries, there's different challenges regarding sexualized drug use. And on the other hand, you also indicated that there is no unified definitions and no unified measurements and tools. So I was wondering, are you in favor that every country, every locality, every university does its own thing? Or do you think we have to move forward and in the international arena agree on definitions, on measurements, and on what is sexualized drug use and what is problematic drug use.
Thank you. I really love that question because I was asking myself the same question before this and I couldn't arrive at an answer. But I think as far as I really believe that I really believe in a regional response or like an international response, and I think there should be a way of measuring something that is more harmonized. I think there will be power to that. However, I think what that means is that there needs to be a comprehensive survey, because if we were to, I mean, right now, let's say if we were to rely on, let's say, consortium and like clinical cohorts, where we might only have the room to include, let's say, 10 to 20 questions, that might be limited, because I think, let's say, even between Singapore versus Thailand, like different forms of stimulants are used, and they also reflect different socio-economic strata. For example, like crystal meth might be something that people use as stimulants, but also I hear like there's like yaba, like different types of pills involved as well. They are also stimulants, but they reflect different ways of using or administering drugs. And I think because of all of these variations, I think there would be a way to measure all these things individually, but also when we want to really think about how we want to group these things in different group or categories of risk, I think there are opportunities to define that, which we haven't properly defined yet. Because I think due to the variations in substances, I'm not so sure if we have data or efforts to really look at, can we say ATS, amphetamine type stimulants, are all the same? And maybe we could then generalize something like that into one type of risk profile. Whereas, maybe let's say if we think about opiates, maybe not so much involved with sex or in sexual context because of the ways that they work or kill like the sex drive. So I think these are some things that I haven't seen, or to my knowledge hasn't been actually done on a more regional or global level yet. But I would be really excited to see something like that happen.
I have a question vaguely related to Chem6 for Professor Martin. Is that we know from our own findings, Purina's IHRI, and also from the previous literatures as well, that people using Chem6, there are some degree of proportion of people who forgot to take PrEP or forgot to use condom. Now, I think we never mentioning or really emphasize to the clients that you should, why don't you ask first whether your partner is taking PrEP or not? So I was wondering from the theme of PrEP surfing, do you think it is worthwhile to, or even if there is any evidence that it is suggested that we should add this into kind of harm reduction surveys in terms of giving education for the clients, that you should ask them first, and then if not, you may have to find some safety net to be aware of. But if they use, okay, then that's all right, in that sense.
Yeah, thank you for that question. I'm not sure if asking that question would actually yield a lot, because you don't know how reliable the answers will be. If somebody is talking about his steady partner, then in most cases you may assume that that information is rather stable, that you can rely on that. But the further away that partner is in terms of stability of the contact, or the degree to which they know and trust each other, then the less reliable the answer will be. So I don't think that's really going to be a very helpful answer or question. Yeah.
So if I just may add, from a psychologist point of view, a lot of the gain frame approach, the message that you are trying to send out is really self-care, right? You have control over your choice in life, that you can protect yourself. And I think that strategy works in our setting better because the stigma and discrimination. If you ask somebody, are you on PrEP? How are you taking it? So I think that strategy works where our contexts are not very open about things. But in a society that most people are openly on PrEP, I mean, PrEP are more available in that country, you have a higher percentage of PrEP user in the country, then it's sort of like normalized. Then you can make social assumption that you can trust those information. So that's your choice. I think it's different strategy that works in a different setting. There's no one better than another. It's just what's best for your setting.
So I have maybe what might be a final question, depending on whether we have any from the audience or not. But I think what's been interesting and something that I see as a common theme in relation to the PrEP services we've talked about and the substance use related services that we've talked about is this kind of difference between perception of risk versus actual risk. Rayner talked about the fact that a lot of her transgender client population didn't perceive themselves as requiring or being at risk or needing PrEP services, when actually if you looked at their behaviors, you could say that they were at substantial risk. In relation to substance use, Meng-Li and I think Rayner talked about this concept of problematic substance use, and not all substance use is problematic, and actually there's a spectrum of substance use. And so my kind of question is actually specifically to Rayner, and it relates to that issue. Do you find, or is there a disconnect between what healthcare providers consider problematic substance use or sexualized drug use and what populations and people consider problematic or not? And if there is, how do you adjust your kind of assessments and screening of that population to account for that difference?
Yeah, I actually just thank you for the question, and I always believe that there is like a sweet spot somewhere, right? I think right now a lot of the approaches assume that communities are passive recipients of care, and I think in substance use, when we think about screening tools, that is the assumption, right? Like, as providers, we are trying to screen all of you so we can identify for you whether you are at risk or have a problem. But actually, the question that I have in that sense is, why don't we have tools that empower people, empower communities to better understand themselves and to better understand their relationship with substances, so that they can be the ones to say that, I have a problem. I think that for me would be an ideal case. It won't capture everyone, because there's also like difficulty in identifying your own problems sometimes. I sometimes don't even know I have a problem until someone else tells me I have a problem, right? So I think it also there should also be like some things that clinicians can do to help people identify these things. I don't really know what it looks like at this point in time, but I think it is a combination of these like risk screening tools, community-based efforts to educate people, and even like I would say that there are some tools that are not really risk screening tools that are used in a lot of community groups. Like even for, let's say, the 12-step programs, there is a pamphlet called Am I an Addict? It has all these lists of questions that ask whether you have faced all these different issues in your life. It's not a screening tool, but it allows someone to contextualize their harms in their own lives to this current list. I think Dean Street Clinic also has a chemsex care plan, and when you go on the website, it asks you, do you want to stop? Do you want to play more safely? Do you want to take a break? Or do you want to, you don't know? I love the I don't know part, because when you go to I don't know, it actually leads you to a whole bunch of questions to ask you, have you missed school because of substance use? Have you lost friends? These are things that help you realize that there are certain harms involved without actually necessarily being a screening tool. So I think it does sound like there are multiple approaches, but landing on that sweet spot I think would be important.
Thank you, Rayner. So I think that comes to the closing of our session. So thank you very much, everyone, for attending our session. I hope you enjoy it. Thank you, our speaker, Professor Martin, Rina, Mengli, and Rayner. And can everyone give me another applause to all the speakers here, all for outstanding speakers we have here. And so that concludes our session. Tomorrow's plenary start at 8:30, where you will see Meng Li again tomorrow. Plenary session and the morning session. Oh, me as well. I almost forgot. At the first session tomorrow. And hope everyone have a great evening in Bangkok. And see you all tomorrow. Thank you.